translating discoveries into practice. It gives me great pleasure to invite our program director, Dr. Mounika, medical oncologist from Hyderabad, to give the opening remarks. Over to you, ma'am.
Thank you. I hope you can hear me.
Yes, ma'am.
Yeah. So very good evening, everyone. Thank you for joining this session. I welcome all the speakers, my panelists, and the other attendees. I'll give a brief introduction about the meeting and also set the context for the meeting. We know that lung cancer is the leading cause of mortality, cancer-related mortality worldwide, and it's the fourth leading cause of cancer-related deaths in India. After imatinib in CML and trastuzumab in HER2-positive breast cancer, probably something which had a very profound influence in oncology was the discovery of molecular pathogenesis of lung cancer, that is the identification of driver mutations in lung cancer, and the subsequent development of drugs which specifically target these molecular alterations. These together have completely changed the face of lung cancer management and also the face of oncology. Because metastatic lung cancer patients whose average life expectancy was just a few months once upon a time are now able to survive for a few years at least with a very good, well-preserved quality of life with just simple oral molecular targeted therapies. And immuno-oncology, immunotherapy, they have opened a whole new chapter in oncology and have further improved the life expectancy of these patients who otherwise have a very grim prognosis. Of course, the immunotherapy drugs are beyond the financial reach of most of our patients, but fortunately, we have generic EGFR targeted therapies, and because of them, many patients, almost all of our patients, are present day able to afford EGFR targeted therapies. And it's very good. It gives great pleasure to see patients improve on simple therapies like oral EGFR targeted therapies. I'm sure we all have a lot of success stories to share about patients who've done extremely well on EGFR targeted therapies, who've responded dramatically well. And today's meeting is a very good platform to share such experiences. Not only that, but not only the therapies, but the treatment, the molecular testing has also evolved over the last decade. The techniques that we are using for molecular analysis have evolved from primitive PCR techniques to advanced high throughput PCR techniques to next generation sequencing or NGS platforms, which we are very avidly using nowadays. Because of the access to these more sensitive molecular analytical techniques, our knowledge about the molecular pathogenesis of cancer is also expanding and it is getting refined day by day. So with this introduction, I would like to start today's meeting, and I hope we have a very good scientific discussion. So for the first talk, I would invite Dr. Venkateshwar Rao, who is a medical and hemato-oncologist at Visakhapatnam, to present an overview of lung cancer. Over to you, Dr. Venkateshwar.
Good evening, ma'am. Thank you for the kind introduction and thank you, Nikhil, for giving this opportunity. Let me share my screen. Slides are visible, right?
Yes, sir. So requesting you to put it into presentation mode.
Yeah. So I will start with an overview of lung cancers. And in the next 10 minutes, I will just speak about the incidence, diagnosis and management part. It will be just a brief overview. So to start with, if you look at the Globocon data, lung cancer is the second most common cause of cancer worldwide. And whereas it's the most common cause. That is, it stands number one among deaths among cancers. And if you look at the numbers, if you see here, nearly 2 million cases of breast cancers are diagnosed, whereas only 1/4 of them are dying. Whereas in lung cancers, it's nearly uh, 1.5 million who are dying of lung cancers. And similar is the situation in India, where lung cancer is the fourth most common cause of cancer, and it's also the fourth most common cause of death. And looking at the numbers, nearly 72,000 new cases are diagnosed, whereas more than 80% of them are dying of it, if you just look at these numbers. The reasons being late diagnosis and even lack of access to the innovative therapies. So we'll be looking into the other aspects as well. And if you look at this data, this is Indian data, where only 14% of the lung cancer patients are diagnosed at an early stage, and majority of them, nearly 44%, have a distant metastasis diagnosis. If I look at my practice, nearly 80% are diagnosed at stage 4, and only we have a couple of patients in stage 1 or stage 2. If you compare it with breast cancers, you can see that only 10% of breast cancers are diagnosed in stage 4. Hence, there is a huge difference among survival outcomes between breast and lung cancers. So the earlier we diagnose, the better is the outcome. It's the same with majority of cancers. And here you can see that patients with stage 1A1 at diagnosis have a 5-year survival of nearly 92%. And it comes down to less than 10% in stage 4. Coming to risk factors, we all know that smoking is the leading cause of lung cancer. And majority of them are smokers. And there's also a second-hand smoke aspect, where people who passively inhale the cigarette smoke are also at a higher risk of developing cancer. There is a small risk in family as well, and other risk factors being exposure to radon gas and exposure to asbestos in glass factories. And also people who have received prior radiation to chest, they also at a slightly higher risk of developing lung cancers. If you look at approach to diagnosis, majority of our lung cancer patients are diagnosed with either a pulmonologist or a cardiac CTBS surgeon. And most of the times they evaluate with a HRCT of the chest or CECT chest and get a bronchoscopy, and we are usually sent with either an FNSC or a biopsy report with a CT imaging. And once they are with us, we stage them with a PET CT in majority of our patients. And if PET CT is not available, then a CECT chest and abdomen with a bone scan and an MRI brain, which differs among different physicians. Some of them tend to get an MRI brain imaging at diagnosis, and some of them skip it when they get a PET CT. Coming to sampling techniques, it depends on the site of disease. In patients with peripheral tumors, we usually get a CT or ultrasound guided biopsy through the chest wall. And in patients where the primary tumor is in the hilar region, we tend to do a bronchoscopy or a EBUS or EUS guided biopsy. Sometimes we are lucky enough to have these cervical nodes or axillary nodes in stage 4 patients, where we can easily get a sample. And in rare situations where the patients are elderly on multiple anticoagulant drugs, where we cannot do a biopsy, we tend to go for a liquid biopsy as well. However, in the era of molecular testing, it's reasonable to get both a tissue biopsy as well as liquid biopsy for these molecular markers. Coming to staging, we do a staging with a PET CT, that is a clinical staging with a PET CT and EBUS or EUS guided mediastinal staging as well. And post-op staging is for early stage diseases, and it's more accurate than this clinical stage. We are following TNM8 staging now, where there are certain differences, slight differences between TNM7 and 8. And TNM8 has classified tumors based on size into T1, which are less than 3 centimeters, and T2, 3 to 5 centimeters. T3 5 to 7 centimeters, and those involving chest wall, pericardium, or phrenic nerve, or a separate tumor nodule in the same lobe, they are classified as T3. And those who have a tumor more than 7 centimeters and tumor which is invading the mediastinum, diaphragm, great vessels, or recurrent laryngeal nerve, or the carina, trachea, and esophagus, they are classified as a T4 tumor. Coming to nodal staging, N0 is no nodal mets, and N1 when they have ipsilateral hilar nodes, and N2 is when they have ipsilateral mediastinal nodes as well, mediastinal or subcarinal nodes, and N3 is when the nodal disease spreads to the contralateral side or to the supraclavicular nodes. Coming to M staging, M1A is the presence of a malignant pleural or pericardial effusion or a separate tumor nodule in a contralateral lobe. And M1B is when they have a distant metastasis, which is a single tumor outside the chest. It could be either a lymph node organ, bone met, or a brain met. And when it is multiple, then it is a M1C. Grossly, we classify lung cancers into non-small cell and small cell cancers, and these small cell cancers account for only 10 to 15%, whereas majority are non-small cell cancers. And these non-small cell lung cancers are again classified squamous and adeno, and there are various subsets in adeno as well, and treatment is decided based on these subsets. Previously, small cell cancers were slightly higher. When we used to study, it was around 20 to 25%. Now the incidence of small cell cancers has come down. However, the survivals, there hasn't been a great improvement in small cell lung cancers. And if you look at this data from India, the overall survival in these patients is less than 1 year. Regarding therapy, since the past 30 years, only 2 drugs, that is a platinum with etoposide, is the main backbone chemotherapy which is being used, and topotecan or irinotecan are being used in second-line therapy. Recently, in the past 5 years, we have seen immunotherapy drugs, that is atezolizumab and durvalumab, which have been accepted in first-line therapy in small cell lung cancers, with only a slight improvement in overall survivals. Coming to non-small cell lung cancers, the therapeutic landscape has changed over the past 15 years, and now that we have this molecular testing, both the squamous cell and adenocarcinoma, we are testing for these molecular markers, and each molecular marker stands for a different type of disease with different clinical aspects, different prognosis, and different therapy. So each one should be treated as a different disease. And if you look at this treatment evolution here, in the past 5 years, you can see that so many drugs have been approved in this based on these molecular markers. We have drugs targeting EGFR, ROS1, MET, RET, and even NTRK. Whereas simultaneously, there have been many of the IO drugs have been approved based on PD-L1 expression. Majority of the IO drugs, which we know, are approved in upfront in non-small cell lung cancers. Those with a PD-L1 expression of more than 50%, we can use a single agent IO, and for less than 50%, we can combine IO with a chemotherapy regimen. And details of all these molecular aspects and treatment based on molecular markers will be discussed by subsequent speakers. If we look at an overview of management, we can grossly classify them into early stage, stage 3, and an advanced stage. And stage 1 and 2 cancers and stage 3 cancers, we need a multidisciplinary approach. We need to involve our surgical colleagues and radiation colleagues as well. And usually, first early stage 1 and stage 2 patients, we tend to get a surgery followed by adjuvant therapy. Whereas stage 3 patients, the treatment is variable, which I'll be discussing in subsequent slides. So, if you look at the stage 1 and stage 2 patients, we can either get away with a wedge resection or a segmental resection, or a lobectomy or a pneumonectomy may be required, depending on the location of the tumor. If the tumor is sitting peripherally in the lung, then we can get away with a wedge resection or segmental resection. For more central tumors, we need to do a lobectomy or pneumonectomy. Not only the location of tumor, but also there are multiple factors which decide whether the patient goes to surgery or not. like age of the patient, various comorbidities, the lung reserve, presence of CPD and cardiac disease, and other fitness aspects for surgery. All of them decide whether the patient goes for surgery or not. If the patient doesn't go for surgery, then we still have an option of SPR, stereotactic radiation therapy for tumors which are less than 5 centimeters. So post-section, we need to treat all these patients with adjuvant chemotherapy, which is cisplatin-based chemotherapy for all stage 2 and above, and for selected stage 1B patients who have poorly differentiated cancers. Previously, with TNM7, we used to have a differentiation where stage 1B, we used to classify patients who have more than 4 centimeters should go ahead with adjuvant chemotherapy. But with TNM8, all these more than 4 centimeter tumors come under stage 2. So there is lesser confusion with this TNM8. And one more aspect to remember is some of the adjuvant trials which have come up have used TNM7 while recruiting. And some of the results which were published previously were based on TNM7. So we need to look into that aspect when we are choosing our patients for adjuvant therapy. And we all know that the latest meta-analysis had showed a DFS and OS benefit with adjuvant cisplatin-based therapy. And all these patients should be treated with cisplatin-based therapy. Despite use of adjuvant chemotherapy, we can say that recurrence rates are very high. Given for stage 1B, the 5-year recurrence rates are nearly 45%, and for stage 3, it's nearly 76%. So despite chemotherapy, majority of them are recurring, and we need to do more for these patients. And recently, we have many trials coming up where we test for molecular markers like EGFR and ALK prior to starting adjuvant therapy, and post-adjuvant chemotherapy, we consolidate with a TKI, either Osimertinib or Alectinib. Osimertinib has been approved for adjuvant therapy, and those who are molecular negative, based on PD-L1 status, we can go ahead with IO drugs like atezolizumab. And when we come to stage 3, it's again a spectrum of diseases ranging from T1N3 to T4N3, and we need to rightly choose our patients for CTRD and some patients for neoadjuvant therapy as well. So those with a peripheral tumor and lesser nodal disease, where the up to N2 can be discussed in a tumor board and taken up for neoadjuvant chemoimmunotherapy. And recent trials with IOs with chemotherapy have shown good major pathological response and good DFS benefits. However, we need to wait for the overall survival results of these trials. And those patients who are not candidates for surgery, they need to be treated with concurrent chemoradiation, followed by durvalumab in the presence of residual disease. Coming to stage 4 cancers, again, as we already discussed, the goal of therapy would be to extend survival and also to improve the quality of life with limited side effects. And we type the patients based on these molecular markers. Majority of them, we are sending a 12-gene panel along with this PD-L1, CPS, and TPS and CPS. And based on the molecular marker which is positive, we start therapy with TKI, and sometimes TKI with chemotherapy as well in younger and fitter patients. And those with a PD-L1 more than 50%, we can go ahead with single agent IO. And patients who are less than 50%, we can combine chemotherapy with IO. And combining strategies have shown improved survivals in these patients. So we all know about what these targeted therapies are and what immunotherapies are. Coming to summary, the 5-year OS in NSCLC is between only 10 and 15%, because majority of the patients are diagnosed at later stages. And also, there are 3 aspects: 1, late diagnosis; 2, limited access to these newer innovative therapies; and lastly, we don't have any screening protocol for our patients. So for improving outcomes, we need to improve upon all these factors, and it should be at the level of primary physician and patient as well. Patients, we need to create awareness among patients and general population, as well as among primary care physicians, because majority of the times what happens with older patients is because they are chronic smokers, these pulmonologists treat them as COPD and do not consider the malignancies in them. And by the time they are diagnosed, it's already stage 4. And for younger patients, they are usually treated like TB. And after receiving 2 or 3 months of therapy for tuberculosis or these high nodes, once they don't subside, then they evaluate for malignancy and then they come to us. And by the time they come, it's already late. So we need to create awareness. We need to find ways to increase access to these novel drugs as well. And by taking all these steps, hopefully we can diagnose cancers at an early stage and improve outcomes in these patients. So I'll end my talk here and thank you for this opportunity.
Thank you, Dr. Venkateshwar. That was a very lucid presentation and a very lucid overview of lung cancer as a whole. A very difficult topic that has been very concisely and very crisply presented by you. Thank you very much. Now I invite Dr. Nikhil, who is a medical oncologist in Hyderabad, for giving his talk on defining targets in metastatic NSCLC. How relevant is liquid and tissue biopsy in clinical practice? So this is a very important topic because now that with the advent of liquid biopsy, it's a big leap forward, and it obviates the need for tissue biopsy, at least in some patients who are too sick to undergo CT-guided biopsy. So over to you, Dr. Nikhil.
Yeah, I hope my slides are visible.
Yeah,
Yes,
your
sir.
slides are visible.
Good evening, everyone. So, as said by the earlier speaker, that we have got a list of molecular aberrations which are seen in metastatic adenocarcinoma, and the list has slowly been increasing. So, there are currently about 12 genetic abnormalities which needs to be tested in advanced NSCLCs. So this is the timeline wherein different molecular abnormalities have been identified, and approximately a decade later, the agents which target these abnormalities have come into clinical practice, have been receiving the approvals, some of them in the second line, some of them moved into the first line therapies. So when we diagnose a patient with advanced NSCLC, so we first establish the histology, whether it's small cell or non-small cell, then subtype it, adeno or squamous. Then we move on to a gamut of testing, that is the molecular testing. And subsequently, we also do the PD-L1 testing. Based on that identified molecular aberration, these patients are categorized or further managed accordingly. So now that the testing has also improved, slowly the testing has moved from stage 4 to earlier stages disease also. So even in stage 1B to stage 3A as well as stage 3B, at least a minimal testing of EGFR, ALK and PD-L1 status is necessary. Whereas in advanced setting, about 8 to 12 gene testing is necessary apart from PD-L1. So in the early stage setting or in the stage 3 setting, the tissue specimen is used for testing. Whereas in advanced setting, the guidelines also suggest that liquid biopsy is as acceptable as that of a tissue biopsy. This is some data which says that those patients who are categorized molecularly and treated accordingly survive longer than those patients who did not undergo any testing and are treated as a blanket. So what are the problems with biomarker testing? The problem can start right from the tissue procurement, processing of the tissue, fixation in the formalin, as well as asking or ordering for appropriate biomarkers to be tested. Then at the laboratory level, the quality of the equipment, the sensitivity, the calibration, all these can also impact the results. And also the final reporting pattern also impacts the interpretation of the results. So an important problem with this is the availability of tissue, because when various data was analyzed, some of our patients reach a hospital after undergoing a biopsy at a peripheral center where the tissue might be inadequate. About 20-30% of the patients may be reluctant to undergo a repeat biopsy to get a tissue, or even if the tissue is there, the tissue might be scanned. So all these pose a challenge in doing the molecular testing and interpreting the results. So there comes the role of liquid biopsy, wherein the cell-free circulating DNA is made use of. So this is used, the circulating tumor DNA or cell-free DNA is sometimes used to look in for various deletions, insertions, amplifications, translocations, as well as point mutations. So as is the advance with the medication, so is the advances in terms of technology and testing. So we have moved from first generation RT-PCR techniques to digital droplets, as well as the second or third generation machines wherein an NGS is being made use of. They are better in terms of the limits of detections or the sensitivity, that is from 1% to 0.1% to 0.01%. And also with the latest machines, we are able to identify some of the partner translocations which are not feasible with the previous generations. So the guidelines say that liquid biopsy can be used or made use of in an advanced setting at initial diagnosis. So whenever any aberration is being picked up on liquid biopsy, it is as sensitive as that being picked up on a tissue biopsy. The specificity is that of 100%. However, liquid biopsy misses about 20% of the aberrations. So the sensitivity is still in the range of 70 to 80%. So anything which is not picked up on a liquid biopsy, that is a negative liquid biopsy, should be interpreted with caution. And if a tissue is available, maybe that can also be made use of to confirm whatever findings have been noted on the liquid biopsy. So as said by the earlier speaker, that there are various ways wherein we can procure a material or the tumor sample for testing methodologies. The one is bronchoscopy, transthoracic biopsies, or pleural fluid, or other bodily fluids, cell blocks, cell cytologies, and sometimes liquid biopsy. So in the curative setting, from stage 1 to stage 3, we have got a biopsy. We can do it, we can test it either from the preoperative biopsy, or when the patient has undergone a definitive therapy in the form of surgery, that can be used. Whereas in a metastatic setting, we have got a liquid biopsy option. So when we compare the liquid biopsy with the tissue biopsy, when various mutations are compared head to head, we can see that the specificity is about 100%. However, the sensitivity is still low, that is about 20%, sometimes 10% different from that of the tissue biopsy. So again, when patients are being treated based on molecular findings and molecular targeted agents, whether they are tested by the liquid biopsy or that by the tissue biopsy, the outcomes are going to be not very different. The advantage with liquid biopsy is that the turnaround time, that is the result or the time to treatment initiation, is shorter compared to tissue biopsy. So here we can see that when we use a tissue digital droplet PCR, it takes 12 days, whereas that with a liquid digital droplet, it takes 3 days. So is the testing with the tissue versus liquid, wherein the liquid NGS comes in around 9 to 10 days. This is what we usually see in practice, and whereas the tissue NGS might take up to 3 weeks. So some of the guidelines also do recommend that at the outset, the patients be tested for both the tissue as well as liquid biopsy. And they say that doing both testing at the same time, there is an increase, about 20% more pickup rate of the molecular aberrations, which might be missed if there is a sequential testing, or if the patients are tested only with the tissue or with the liquid. So liquid biopsy is useful when patients does not want to undergo a repeat biopsy because of tissue scarcity, or they don't want any invasive procedures, or it can be used as while the patients progress on therapy, so that it reflects the tumor evolution or the clonal evolution, and also reflects the tumor heterogeneity. So again, the same depicted here, that the changes which are picked up on a liquid biopsy when they are treated appropriately with molecular targeted agents, that there is a response or the patients do well. This has already been said, but the only concern with doing simultaneous testing of the liquid and tissue is that the cost goes exponentially high, and it may not be covered by the service providers or the insurance companies. So that's why it's not been commonly practiced in our setting. though the testing with liquid biopsy is validated in stage 4, the emphasis or its utility in stage 1 to stage 3 is not that great, and it needs furthermore data to really impose that it is also replaceable to that of tissue biopsy in stage 1 to stage 3. So from this, we can say that the liquid biopsy acts as a complementary or alternative testing. And in certain situations where a tissue is not available, you can go in for liquid biopsy. So the pathway is like that if you've got a tissue, you can go in for a NGS, or if you don't have a tissue, then you can do a plasma or a liquid biopsy. And based on what is being seen on that, whether it warrants a reflex testing on the tissue, then you can go further. So the disadvantages with liquid biopsy is that we'll not be able to identify the histological transformation at the time of disease progression. And also the PD-L1 testing or the non-DNA biomarkers cannot be evaluated on a liquid biopsy. And about 20% of these aberrations can be missed, especially amplifications in the MET can be missed on liquid biopsy. So what are the recommendations in terms of liquid biopsy? So these are recommended in patients. Wherever it's possible, you can do it the same go, or it can be used as a complementary testing methodology. And in certain special situations wherein patient doesn't want. But we should also understand the implications or the limitations of doing a liquid biopsy. Again, the NCCN guidelines also recommend the same. And we should also be aware that there are certain aberrations which are, because liquid biopsy captures DNA, which is sometimes released from healthy dying tissues, normal dying tissues. So some of these changes can also be picked up and seen on the report. So these have to be interpreted with caution, because, for example, in a metastatic breast cancer patient, sometimes you may get to see ET790M mutation. So, or in a colon cancer, once in a while, you may get to see some EGFR mutation, but that doesn't imply that these patients can be treated with that particular molecular aberrations. And some of these might also be from the chip mechanism or the clonal hematopoiesis of indeterminate potential, whereas which leads to these changes which are being seen in the testing. So the takeaway is that the molecular testing is quite important. You can do it on a tissue or a liquid biopsy. The liquid biopsy has got advantages. It has a shorter turnaround time and short time to treatment. And the issues with the processing of tissue are simply avoided by doing a liquid biopsy. So the results or outcomes are going to be the same. Thank you.
Thank you very much. So we'll proceed with the next talk, that is managing EGFR mutated non-small cell lung cancer in today's clinical practice by Dr. Rohit Reddy, who is a medical and hemat-oncologist from Hyderabad. Over to you, Dr. Rohit.
Thank you, Dr. Mounika, ma'am. Thank you, team AstraZeneca and team Merck for today's webinar. So briefly, I'll be discussing about mostly about Osimertinib. Why are we recommending it as a first-line treatment option for all EGFR mutant metastatic non-small cell lung cancers? I just share my slides. So this is something which we have already seen, that lung cancer is one of the most common cancer being diagnosed worldwide, and it's also a major cause of cancer-related mortality. And among these lung cancer patients, especially among non-smokers, at least 30% of our patients show some sort of EGFR TKI sensitizing mutations, and majority of them occur between the exon 19 to 21. The common mutations that we see are occurring either which is a deletion of exon 19 or a mutation in exon 21, which is L858. Apart from this, we can see certain other rare mutations, the G719 mutations, which usually respond to afatinib. And often but not late, we are also seeing more of exon 20 insertions. And as previously discussed, EGFR testing is now recommended even in early stage non-small cell lung cancer. It has been endorsed by the NCCN guidelines. So this is a brief overview of the current treatment options which are available for advanced lung cancer. We have all these molecular testings like ROS, ALK, EGFR. This has been already elucidated. And these are all the chemotherapeutic options which are available. Today's topic of interest would be predominantly the EGFR mutation and Osimertinib. So now, why would we recommend EGFR Osimertinib as a go-to choice for all our patients? See, Osimertinib is a third generation irreversible and CNS active EGFR TKs, which are selective both for EGFR mutant and EGFR T790M resistant mutations. We know that most of the patients who have been started on first or second generation EGFR TKs, ultimately, this 50% of them develop EGFR T790M mutations. And apart from that, many of them ultimately start relapsing in the CNS. So having a drug which can penetrate the blood-brain barrier actively and also act on EGFR T790M resistant mutations, it makes sense that it would definitely do better than the first generation EGFR TKs. And with this basic concept came FLORA trial. Now, what is FLORA? They include, it's a phase 3 double-blind trial, which was conducted actually across 29 countries. This was a key inclusion criteria. They included only exon 19 deletion and L858R mutation. They did not take the rarer mutations. And no prior systemic anti-cancer or EGFR TK therapy was allowed. That means it was a first-line treatment. And in this, they have randomized between Osimertinib or the first generation EGFR TKs. The dose of Osimertinib here being 80 mg. And now, again, the primary endpoint of this particular trial was PFS, which was based on investigator assessment. The other key secondary endpoints definitely were overall response rate, duration of response, the disease control rate, the overall survival. No, the baseline characteristics were well balanced. There was a good male to female ratio. The races were matched. The smoking status was matched. The CNS metastasis, almost around 20% in each arm had CNS metastasis at study entry. Now, the primary endpoint was investigator assessed PFS. This was never seen before. Almost the median PFS with Osimertinib was nearly around 19 months as compared to the first generation EGFR TKs, which was around 10.2 months. In this particular trial, a crossover was also allowed. Now, the hazards were significant. The hazard ratio here was 0.46, the p-value being less than 0.001. So it met its primary endpoint and definitely it reduced the progression of disease. This is one of the very interesting forest plots. We rarely come across forest plots like this. Most of the subgroups were actually favoring Osimertinib. This, irrespective of sex, age, race, the smoking history, whether there was CNS metastasis, irrespective of whether it was an exon 19 deletion or an L858R mutation. The objective, one of the key secondary endpoint was objective response rate. The objective response rate was also definitely higher. And this was actually the first EGFR TK which had shown a significant OS benefit. Despite that, in that particular trial, 47% of the patients who were on control arm, they actually crossed over to the treatment arm. But despite that, the median OS was significantly increased in the arm who had received Osimertinib as a first-line treatment, which was almost 38.6 months, as compared to the EGFR first generation TK, which was 31 months. Here also the hazards were significant. And when we understand that a particular drug is both effective in terms of PFS and OS, we also would want it to have lesser side effects. The side effects were almost comparable to the first generation EGFR TK. The predominant side effects, the most of the side effects that we also routinely come across in our OPDs are these dry skin, paronychia, and diarrhea. So these are, and most of them are actually manageable. We do not need to decrease the dose of Osimertinib. Sometimes just with plain medication, they get controlled. So the summary was that Osimertinib resulted in a highly statistically significant and clinically improvement PFS over the standard of care. There was definitely a clinical improvement noted in terms of CNS PFS. The final analysis also showed that the survival trend favored osimertinib. So based on this, osimertinib was approved by FDA as first-line therapy for EGFR mutant advanced non-small cell lung cancers. Even if we see certain intricacies in the trial, such as CNS efficacy, now why CNS metastases are important? Because they occur at higher rates as compared to the patients who do not have an EGFR mutation. In patients who have EGFR mutations, at baseline itself, around 20% of the patients have CNS metastasis. Even during the follow-up, it's almost 44% as compared to the wild type, which is only around 10% and 22% respectively. So this is important for us. So if we have a drug which penetrates the blood-brain barrier actively, we would definitely go for that particular drug. So now this was reflected within the trial. If we specifically looked at the CNS PFS, the median PFS with osimertinib was 15.2 as compared to 9.6 months. The hazard again here was quite significant. Even without CNS metastasis also, there was a good benefit in terms of median PFS. Now we have one more particular drug, dacomitinib. Now, why don't we prescribe dacomitinib as our go-to drug for our patients? See, this is a, with all its caveats, this is a cross-trial comparison. The Archer 1050 trial, it had used dacomitinib as compared to gefitinib. Here also, the median PFS was around 15 months as compared to 9 months. The hazards were significant. But an important point to remember is that there was an immediate separation of the Kaplan-Meier curves with the osimertinib drug, whereas the separation was seen after 6 months in the dacomitinib Archer trial. And numerically also, if you see, it's only 15 months in the dacomitinib arm, whereas it was around 19 months in the osimertinib arm. The OS was not statistically significant because the key one in this particular trial is statistical. The method, the formal comparison which was used was a hierarchical method, and they had actually assumed that before going for an overall survival analysis, the response rates had to be significant. Here, because the overall response rate was not statistically significant, the OS was not studied. But also, this was the first time when an EGFR TK had translated into a significant OS benefit. That is, despite crossover, osimertinib had definitely proved its strength. Now, we also know that we have a second generation EGFR TK, afatinib. Let's briefly through it. Here, the median PFS was only 11 months as compared to almost 10.1, 10.9 months in gefitinib. There was no survival benefit as compared to gefitinib. Definitely, we would prefer afatinib in rarer mutations, but not with the routine mutations. And if you actually compare all these drugs side by side, osimertinib is the safest drug. We routinely use in our OPDs. Many of my patients are actually very tolerable to osimertinib. But when we go to the second generation EGFR TKs such as afatinib, it becomes very difficult. Most of them have some sort of skin rash, mucositis, diarrhea, etc. So this was what already that we have discussed, that it's a sequencing arm. Almost around 47% of the patients have received osimertinib, but despite that, there was a very good benefit starting osimertinib in the first line. Now, why do we need to start it in the first line? We all know that at least 30% of our patients do not they are not eligible to receive a second line therapy. Hence, you have to use the strongest treatment possible within the first line so that you give maximum benefit to these patients. So even after this brief discussion, we know that NCCN guidelines also recommend osimertinib as its category 1 recommendation for EGFR mutant metastatic non-small cell lung cancer. Now, a brief discussion about newer therapies which are happening. Now, this is an interesting study which was published in NEGM in November of 2023, the FLORA2. Now, we all know that we have a EMS study which had seen combination of gefitinib with chemotherapy versus gefitinib alone. And in that, there was a very good significant median PFS benefit. Now, there is a brief theory that osimertinib does not act on all EGFR mutant lung cancer patients. There might be certain clones of cells which are present in certain patients, which may become resistant to osimertinib quite early. Hence, we assume that this adding chemotherapy in such patients might help in long term. So this was the key point behind designing a FLORA-2 phase 3 trial. Here again, they've taken EGFR exon 19 deletion or L858R mutation. They were untreated metastatic or locally advanced patients. They had used a combination of osimertinib with chemotherapy. The chemotherapy here being pemetrexed, carboplatin, or cisplatin, followed by maintenance osimertinib pemetrexed versus osimertinib alone. Again, the primary endpoint here was median PFS. These are the other key second endpoints. The baseline characteristics were well matched. Again, in this particular trial, there was a significant median PFS improvement. In the comparator arm, the median PFS was 16.7 months as compared to the original FLORA trial, which we had seen a median PFS of around 18.9 months. Now, we do not know what is the exact reason for lower median PFS in this particular trial, but the combination arm, the median PFS was almost around 26 months. So this was never seen before, at least with respect to first-line therapies in EGFR mutant lung cancers. So even as per blinded independent review, the median PFS, there was a significant median PFS benefit. Now, across all subgroups, there was a significant benefit with the combination in terms of PFS. And there was an interesting point which was seen that the time to second progression-free survival was also significantly improved in the combination arm as compared to osimertinib arm. There is no significant median overall survival benefit as of now in terms of OS. The combination definitely had a higher side effects as compared to osimertinib monotherapy. Now, an important takeaway from this particular trial was that, see, you do not give the combination in all our patients as of now currently. Now, which are the subgroup of patients whom I would definitely prefer this combination? I would say it would be a young fit patient, probably with CNS metastasis at baseline. So these are some subset which I would want them to have a longer median PFS, because the side effect profile is definitely higher as with the combination therapy. Now, I do not want them to get exposed to a higher side effect profile when we do not have a significant overall survival benefit as of now. Then this was one more interesting trial, the Mariposa trial. Now, most of these patients who are on osimertinib, they ultimately become resistant to it either by acquiring a secondary EGFR mutations or MET mutations. So amivantamab is a drug, it's a bispecific antibody which targets both MET and EGFR. So it was combined with another third generation EGFR inhibitor, lazertinib. The comparator arms were osimertinib and lazertinib. Definitely, it showed a significant improvement in terms of median PFS. The PFS benefit was consistent across various predefined subgroups. The overall response rate was higher. The interim OS did not show any benefit as of now, but important to know that this particular combination is toxic. See, you can see that the adverse events are definitely higher. In the grade 3 adverse events were noted in more than 75% of the patients. Predominantly, these side effects include cutaneous toxicities, ILD, and DVT. Now, this is an interesting final summary slide which I found. Now, after first-line osimertinib, after seeing a progressive disease, we go for a liquid biopsy or a tissue biopsy. Now, these are previously it was only chemotherapy, but now we have so many other options which are coming up. Definitely, I think the field is going to change rapidly. Now, for conclusion, for the first time in EGFR, among all the EGFR TKs, osimertinib was a drug which translated, there was a good PFS and OS benefit. Even the efficacy was observed with respect to CNS metastasis. It's a better tolerable drug. Hence, for all our patients now, the standard of care for first-line therapy would definitely be EGFR mutant, would definitely be osimertinib. The only caveat is that it's an expensive drug. Thank you.
Thank you, Dr. Rohit. That was a very nice presentation with all the important trials covered regarding as far as EGFR targeted therapy is concerned. So now let us proceed with the panel discussion. And I would present one or two cases of patients who had very good and dramatic responses to Osimertinib. And I'm inviting my panelists. I hope all of them are present. Dr. Venkateshwar, Dr. Lakshmi, Dr. Naveen, Dr. Nikhil, Dr. Rohit Reddy, Dr. Praveena, and Dr. Sindhura. I hope all the panelists are present. I'll share my screen. I hope all of you can see the screen. See my slides?
Yes, ma'am.
Yes, ma'am.
Yeah. Okay. So let us take this forward, and I hope in this panel discussion, we'll be able to discuss a few very relevant clinical points, which we all follow in our day-to-day clinical practice. And there may not be one right answer for whatever questions I would ask. These are the frequent questions that we keep pondering over in our day-to-day clinical practice. So here is a case of a 64-year-old gentleman who presented with cough, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days. He was also experiencing some giddiness over the last 5 to 6 days and weight loss of about 5 kgs in the last 1 month. He's a non-smoker. So a PET scan was done, all evaluation was done, a malignancy was suspected, and after initial chest imaging, an X-ray that showed a suspicious mass, a PET scan was done, and it was seen that there was a mass lesion in the right upper lobe with hilar nodes. The nodes were bulky, about 4 into 3 centimeters, and multiple bone metastases were also seen in the biopsy. So otherwise, this gentleman was quite fit, but because of the pain, he was ECOG performance status 2. So my question to Dr. Venkateshwar, in this case, what would your preference be? Would it be a tissue biopsy or a liquid biopsy in this patient? He's otherwise fit. He's not oxygen dependent or anything. He is just in severe pain and there is giddiness because of the brain metastasis. So otherwise, there is no contraindication as such for tissue biopsy. But would you prefer a liquid biopsy or a tissue biopsy? If tissue biopsy only, what are the reasons?
I would go ahead with a tissue biopsy first, and the reason being I'm comfortable with the tissue biopsy. I've been using it.
Okay. Any other reason? Dr. Lakshmi, would you be able to tell
Since my DM days, and recently I
Dr. Venkateshwar, we can't hear you.
ideally it would be ideal to get both a tissue and liquid biopsy, but for various reasons, financial aspects as well, I usually go with the tissue biopsy first.
If finances are not an issue, would you do liquid as well?
Then ideally I would do both.
And the reason for that is?
We can pick up more mutations. The chances of picking up these mutations are 10 to 20% higher when we combine both these testing modalities.
Correct. Because tumor heterogeneity is one concept which is evolved in the recent times, and that heterogeneity it's more representative what we get from the peripheral blood, because it's a circulating tumor DNA that is analyzed, and this DNA is shed from the entire tumor randomly. So there is more chance that we would pick up that entire heterogeneity is more represented in a liquid biopsy sample rather than a tissue sample. But first of all, the histology is also very important. So tissue biopsy is mandatory. We cannot replace a tissue biopsy with a liquid biopsy unless the patient is very sick and is not able to, is not in a position to withstand a CT-guided biopsy or image-guided tissue biopsy. That is probably the only scenario where we would just go for a liquid biopsy, or if the family is not keen on or is not consenting for a tissue biopsy. This is a common scenario. We do frequently face this situation where the moment you say it's probably a stage 4 lung cancer, the family doesn't want a tissue biopsy. So in that case, we go for a liquid biopsy, but otherwise for all other practical purposes, tissue biopsy is a must. And wherever possible, we can complement it with a liquid biopsy. So in this patient, this diagnosis and presentation happened in the year in the year 2020, and biopsy was done from the lung mass. It was an adenocarcinoma. It was TTF1 positive and NAPSIN A positive, and it was negative for P40. So that excludes the squamous histology. On molecular analysis, the patient was found to have EGFR exon 19 deletion, and all other driver mutations were negative. PDL1 was also not getting expressed. So because he presented with giddiness, an MRI of the brain was also done, and that was done in November. That's a few weeks after the initial diagnosis. And the patient was found to have multiple ring-enhancing lesions in the cerebellum and the cerebral hemisphere with a significant perilesional vasogenic edema. So, Dr. Lakshmi, tell me, would you do an MRI in an asymptomatic patient at baseline in a stage 4 NSCLC patient? If on PET there is metastatic disease at other places like bones or liver or multiple lung nodules, and the patient doesn't have any CNS symptoms, would you still like to do an MRI at baseline?
Yes, madam. I would like to do an MRI at baseline if the financial thing is not an issue.
Okay. The reason why
in
you
all
would
stage
want
4
to do it
patients.
in an asymptomatic patient?
To rule out any baseline disease, madam, because after treatment, if the patient presents with symptoms, we will not know if it's a progressive, if there are new lesions or the disease was presented.
Right, right. Dr. Naveen, any other view on this? Would you do a baseline MRI or a neuroimaging in an asymptomatic patient? Asymptomatic as in asymptomatic for CNS disease. And you know that it's a stage 4 cancer. Do you still see a benefit of doing the imaging at baseline?
Yes, my PET-CT is negative and patient is asymptomatic. Also, baseline MRI scan is indicated because the latest development of drugs, because if the patient is having asymptomatic brain mets also, we have a lot of drugs which have a better CNS.
Correct.
So
yes.
Going for a drug rather than usually is because in PMH what we practice is if PET-CT is negative, we do a MRI brain. Having 1 or 2 brain mets, no metastatic sites elsewhere, we do an MRI brain to rule out whether it is oligometastatic or nothing. But if PET-CT is showing multiple brain mets, we usually avoid MRI brain.
Then there is no point. If there are multiple brain mets which are visible on PET itself, there's no point in doing MRI because we know there are multiple brain mets, then we would proceed with the further treatment. But as you rightly said, if it's just showing 1 or 2 mets, then it's worthy doing an MRI because it's much more sensitive as far as brain parenchymal metastasis is concerned, as well as leptomeningeal disease also. Then we can take our treatment decisions. Are you treating with a curative intent or a palliative intent in a patient? If it's really oligometastatic, then we can give a curative shot also. And also, as you rightly said, the choice of systemic therapy that we would use, we would prefer to use drugs which have a better CNS penetration in patients who have a brain metastasis, even if they're asymptomatic. So if in EGFR TKIs we have to choose, we would choose Osimertinib because it has a very good brain penetration. The final diagnosis of this patient was stage 4 non-small cell lung cancer with exon 19 deletion with bone and brain metastasis. So this case was managed with local radiotherapy for the metastasis, including mainly the bone metastasis. So the management plan was formulated as radiotherapy for the metastasis, both bone and brain, and along with that EGFR TKIs for the exon 19 deletion. So Dr. Nikhil, what would be your preferred first-line EGFR targeted therapy in this particular patient at baseline?
I would use Osimertinib, the 3rd generation EGFR TKI.
Yeah. So managing a patient with EGFR mutated NSCLC in the first line, with first, second, and third generation TKIs, if you see, we have all these are the landmark trials which have led to the approvals. And if you look at the median PFS in the experimental arms, it was around 9.5 months for Geftinib in the IPASS trial. Erlotinib, it was 13 months in the optimal trial. And in the Lux Lung 7 trial, Afatinib gave a PFS of 11 months. Dacometinib in Archer 1050 gave a median PFS of about 15 months, and the maximum median PFS we have seen in the Flora trial with Osimertinib, which is about 19 months. So, of course, this is a cross comparison of trials, but just to get a estimate of what is the PFS that was achieved historically in trials with the various first, second, and third generation TKIs. And we know that Osimertinib demonstrated even in the preclinical studies in animal experiments also, higher mouse brain concentrations of the drug were achieved as compared to the other TKIs. So that's how we know that compared to all other TKIs, the CNS penetration of Osimertinib is excellent. And this was also seen in the MR PET, which was done. And based on that, when they assessed the CNS penetration of Osimertinib, it was found to be quite superior. And so this is like the volume, the CNS volume of distribution of Osimertinib on PET parametric images. So that also showed a very good volume of distribution for Osimertinib. So in a patient, while managing a patient with EGFR mutated metastatic NSCLC and CNS metastasis, Dr. Rohit, can you take this question? Do all asymptomatic patients with incidentally detected brain metastasis, like on the PET, you see 1 or 2 metastases, you do an MRI, and there are 1 or 2 metastases in the brain parenchyma, or say, for example, there are multiple metastases or 1 or 2 metastases, whatever it may be, there are asymptomatic brain metastasis, patient doesn't have any symptoms. Do you send every such patient for radiation along with the systemic therapy?
If it's an asymptomatic CNS metastasis, definitely we do not recommend radiation, because now we have a very potent drug which actively penetrates blood-brain barrier, that is Osimertinib. So definitely many of my patients can be managed with Osimertinib without giving any local therapy in form of radiation or surgery.
And if you're not able to give Osimertinib to the patient because of financial constraints, would you then push
Then definitely I
radiation?
would go for initial radiation treatment followed by first generation EGFR TKI.
Right. Dr. Praveena, any different view on this?
No, ma'am, I concur with Dr. Rohit. If asymptomatic brain mets and patient is affordable to take Osimertinib, then I do not offer any local therapy. I would directly proceed with Osimertinib.
Right.
If patient is not affordable for Osimertinib, then only I would offer local therapy followed by first generation TKI.
And if the patient is symptomatic?
Symptomatic local therapy followed by radiation followed by TKIs.
Yeah. Have you used concurrently with radiation TKIs? Do you think there is any contraindication?
No, ma'am. Actually, if systemic disease burden is not high and patient is not much symptomatic, not having much lung symptoms, then we can start TKI after completion of radiation. If along with CNS symptoms, if cough, breathlessness are also severe, then maybe I would like to start both upfront.
Yeah, correct. So, if at all there is a if it's just 1 or 2 metastases and we are actually going for SRS anyway, it will be just 1 or 2 fractions. We'll complete the SRS and then we can start the systemic therapy with Osimertinib. So, as you rightly pointed, if the patient has asymptomatic brain metastasis and we are able to give Osimertinib, then we need not push them for radiation to the brain. Even if it's an SRS, it's not required if it's asymptomatic, but symptomatic brain metastasis, definitely we need radiation. If there are multiple brain metastases and patient is still asymptomatic, again, we will not go for radiation if the patient doesn't have symptoms, if we are able to start Osimertinib. If for financial constraints, we are unable to give Osimertinib, then we can go for radiation, whole brain RT if multiple brain mets are there, or SRS for limited metastasis, number of metastases, and then followed by either first or second generation TKIs. This is for newly diagnosed patients. And if there is progression on first or second generation EGFR TKI, so if there is progression only in the brain, then again we assess, is the progression symptomatic or asymptomatic? Because many times we do see this scenario where we have used a first or second generation TKI. Systemically, the disease has responded very well in the lungs, bones, everywhere there is a response, but there will be 1 or 2 new lesions in the brain. or 1 or 2 lesions in the brain which were not there at baseline. They may be seen on PET itself. PET was negative for Mets in the beginning, or the Mets might have been very small in the beginning. And since PET sensitivity is very poor as far as brain disease is concerned, we may not have seen them. And when we use first and second generation TKIs, because their brain penetration is less, the brain metastasis might progress, but the systemic disease responds very well. So if the patient is symptomatic and there is progression only in the brain with response at other places, then so what would you do, Dr. Sindhura? Can you take this question? Would you change the systemic therapy, or would you continue the systemic therapy and offer local radiation?
So would continue the systemic therapy and offer local radiation.
Right. And if at all there is if there is a symptomatic progression, then yes. If there is an asymptomatic progression and the patient doesn't have any symptoms, so there's no indication for radiation, but yes, patient has developed a new metastasis in the brain. So is there any role, do you think there is a role for a repeat biopsy here, Dr. Sindhura?
So if it's an single brain metastasis, in that case, I would consider an SRS and go for, because biopsy in such a case would again be a TDS thing. So in such a case, I would go for an SRS and continue the same therapy.
How about a liquid biopsy at this stage to see if there is T790M?
So if it is only an definitely a liquid biopsy if the patient is on a first generation EGFR TKI.
Yes. So here the patient is not on Osimertinib. Patient was on first or second generation TKI. So we can do to consider whether we need to change to Osimertinib to offer the option of Osimertinib to this patient if at all they're affordable. Then we should do a liquid biopsy for T790 because brain biopsy may not be feasible always. It's something which we rarely do. It is difficult. So then we will have to go for a CNS. Then we'll have to go for a liquid biopsy to assess the T790M mutation and then put the patient on Osimertinib if affordability is there. So if T790M is negative, then we can again go for either an SRS or a whole brain RT. And if the systemic disease is responding well, it's just CNS progression, either in the form of a single 1 or 2 metastases or multiple brain mets. We go for SRS or whole brain RT depending upon the number of brain metastases, and then we continue the same TKI. So if there is a CNS as well as a systemic progression, then again, it remains the same. We always do a repeat biopsy from wherever possible. If possible, we can do repeat biopsy because T790M, yes, it's the most common mechanism of resistance to EGFR TKIs first generation, but there are other ways by which EGFR resistance can emerge to EGFR first and second generation EGFR TKIs like small cell transformation. So for that, we will have to go for a repeat tissue biopsy. So if there is a systemic progression, we have an opportunity. We usually choose one new lesion wherever there is progression, either in the liver or the lung or any new node which is emerging or which is progressing in size. We can always choose that particular place to do a biopsy and look for T790M. If that's not feasible, if there's no biopsyable site, but the disease is progressing, like skeletal progression is there or brain progression is there, then again, we can go for a liquid biopsy. So we know that this concept of oligo progression is there. Dr. Naveen, what is your take on this concept of oligo progression? Do you think it is something which makes sense that we continue the same systemic therapy and we just treat the site which is progressing with a local therapy if feasible?
Yes, ma'am. Suppose the patient is having oligo progression, better to continue if suppose the patient is on Osimertinib. My take is that to continue Osimertinib as long as the patient is controlled extrathoracically or suppose oligo progression in the brain or some new onset bone lesions or brain lesions. If it is oligometastatic, treat it with locally and continue the Osimertinib till the patient progresses with multiple lesions.
Right.
Because the patient will have that EGFR TKI sensitivity still will be there. So new onset mutations may come, which will be seen in the liquid biopsies, but still some part of mutation, EGFR sensitivity, the patient will still have. So better to continue that, whatever the TKI is on, to continue the TKI.
Right. Yeah. So this, so now if you look at the PFS benefit in FLORA, from FLORA, if we see the brain outcomes, Osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status. So this is with known or treated CNS metastasis. There were about 116 patients, and about 440 patients did not have any treated CNS metastasis. So here, if you see, the median PFS was 15.2 months versus 9.6 months in patients with CNS metastasis with a hazard ratio of 0.47, which was statistically significant. And if you look at the patients who did not have CNS metastasis, the median PFS was 19 months versus about 11 months with a hazard ratio of 0.46, which was also statistically significant. So patients who had CNS metastasis also did very well, and Osimertinib had its PFS benefit even in that subset of population. Now, if you look at the other trials, brain outcomes, if you see the Lux lung trials, patients who had asymptomatic brain metastasis were included in the Lux lung trials, both 3, 6, as well as 7, they were included. And the median CNS PFS was 8.2 versus 5.4 months. So this showed some benefit, but however, the brain metastasis responses, this is the overall systemic, responsiveness, but the CNS responses were not separately reported here. And then if you look at the Dacometinib trial, that is Archer 1050, brain metastasis patients were completely excluded, and that was mandated via a scan at entry. So patients with brain metastasis were completely excluded. And then we have Osimertinib, the FLORA trial, where Osimertinib was compared to Geftinib or Erlotinib, and patients with baseline asymptomatic CNS metastasis were excluded. And the median CNS PFS, which was assessed by an independent review committee, a blinded review committee, it was 15.2. So this is the CNS PFS. It was 15.2 versus 9.6 months. And this is the systemic response, whereas as far as the CNS is concerned, the median PFS was not reached versus 13.9 months. So intracranial or CNS response was not assessed at all, although they did include in Lux lung trial with afatinib, they did include patients with baseline asymptomatic brain metastasis. The CNS responses were not assessed in Lux lung trials, and systemic clinical benefit was observed, however, with afatinib as compared to chemotherapy, but it was not observed with Geftinib. Then systemic and CNS clinical benefit were observed with Osimertinib as compared to Geftinib and Erlotinib. And patients with brain metastasis were completely excluded from the Dacometinib trial. And data on brain metastasis were not gathered in either the Erlotinib or Geftinib global clinical trial program. So we don't have the CNS data specifically for these two drugs. So as of now, the strongest CNS data comes for Osimertinib only, as far as the CNS responsiveness, CNS PFS, and CNS response rates are concerned. So, for this patient, there were, for bone metastasis because of pain, he was started on palliative radiation to the spinal metastasis, and he was also given bone modifying agents. And for brain metastasis, radiation was offered, but patient denied to take brain RT, and he wanted to consider this treatment option a little later. So he was started on first-line TKI, Osimertinib at 80 milligrams per day. Dr. Venkateshwar, what is your toxicity experience with Osimertinib? How do you find the drug being tolerated, and what are the common side effects or toxicity that you see in your patients while giving Osimertinib?
Osimertinib as a single agent is very well tolerated when compared to other first generation TKIs. Yeah. And I never had to discontinue Osimertinib because of any toxicity. Though we theoretically some toxicities are mentioned, but my patients, they do well with Osimertinib. I have 4 or 5 patients, and most of them did well.
Yeah. Dr. Lakshmi, how about your experience with Osimertinib toxicity? Did you find any specific toxicities? Do you monitor for QTC interval in patients who are on Osimertinib? Do you regularly do it?
Actually, the number of patients who are on Osimertinib at my practice are very few, madam. Only one or so.
Okay.
So they are tolerating very well, madam. I
Yeah.
don't regularly do QTC.
Yeah. So that's in general, most of our experience, I guess, with Osimertinib, we see the patients tolerating them very well. We generally don't see the skin rash or the mucositis or the diarrhea that we see with Erlotinib, Geftinib. It's very, very minimal with Osimertinib. Hardly any patient has a beyond a grade 1 rash or loose stools. And QTC prolongation, we do see in some patients, but we just have to be a little cautious if we are using any other QTC prolonging drugs in patients who are on Osimertinib. Like before prescribing macrolides like azithromycin, we have to be a little careful because both these drugs combined together might cause a significant QTC prolongation, especially if patient has underlying cardiac comorbidities, then it might become a problem. Otherwise, routinely, we don't actually have to keep monitoring the ECG unless the patient has something symptomatic. We do not, routinely do an ECG in these patients. So the follow-up PET scan was done in March 2021. So that's roughly about 4-5 months after initiating the treatment. The scan was done, and it showed that the right upper lobe lesion encasing the upper lobe bronchus, it had decreased by almost 50% from about 4 centimeters to 2.2 centimeters. The right hilar nodal mass and the paratracheal nodes also, they had a significant reduction in size. So effectiveness of TKIs in brain metastasis, if you see Osimertinib versus Erlotinib or Geftinib, this is there. So if you look at the patients, those who have in the CNS full analysis set, if you see the response rates are 66% versus 43%, and the disease control rates are 90% versus 84%. The median CNS duration of response is not reached with Osimertinib as compared to about 14.4 months with Erlotinib or Geftinib. And if you look at the subset in the CNS evaluable, patients with CNS metastasis who are evaluable for responses, then the Osimertinib response rates, CNS response rates are much higher. They're close to 90% as compared to 68% with Erlotinib or Geftinib. And the disease control rates are 95% versus about 90%. And the median CNS duration of response is 15 months versus 18 months. So this difference is, of course, not statistically significant. So that's how, so the CNS responsiveness is definitely much better, including the disease control rates, and the overall response rates are much more superior with Osimertinib as compared to the first generation TKIs. So when a follow-up MRI brain was done in February 2021, there was a complete disappearance of all the ring-enhancing lesions that were seen, and there was no additional intervention. So if you remember, this patient refused radiation at baseline to the brain. He only took skeletal RT, and Osimertinib worked so well for him that radiation could be completely avoided. We know that whole brain RT is associated with a lot of morbidity on the long run. Once upon a time, it was used very, very frequently, very avidly, because the patient's survival was very limited to about 1.5 years when chemotherapy only was the option for metastatic NSCLC. But now, as I said earlier during my introduction, with the TKIs which we have, whether it's EGFR or ALK inhibitors, they are surviving for many years. They're surviving long enough to experience the side effects, the cognitive defects that can ensue because of whole brain RT. So it's very important to try and avoid whole brain radiation as much as possible, even if it's hippocampal sparing. They do experience a lot of cognitive problems. And if we can avoid it because of a drug with such a superior efficacy in the brain, such good brain penetration, then there's nothing like it. So no additional intervention or radiation has been required for this patient so far. So this is the first case. And so now we don't see these kind of responses in all the patients. Some patients respond beautifully to Osimertinib, whereas some patients don't respond that well. So Dr. Praveena, do you think that the patients who respond really well, do you think they're different from those who don't respond at all?
You see the mutation, patients with exon 19 mutations respond very well compared to exon 19 deletion respond very well compared to exon 21 mutations, ma'am. That is my observation.
Yeah.
Other than that, I don't know any specific subtypes subgroups that respond well.
Yeah, exon 21 is not responsive to any of the usual EGFR TKIs. That's why we have other drugs, exon 20 also, exon 20 insertions also, they don't respond well. L858R and exon 19 deletions are the ones where we see the best responses to osimertinib. But even in these patients, again, not all of them have that good PFS which is shown in clinical trials. We often see exon 19 patients sometimes, they may not be very common, but we do see that sometimes these patients within the first response assessment, they are good, they have a partial response, but by the time they come for their second response assessment, about 6 months from the time of initiation of osimertinib, we see that they've progressed. So the PFS is so short in some patients. So probably they have additional mutations and additional downstream signaling pathway, any components of the downstream signaling pathway, if there are additional mutations which are causing a quick resistance to emerge. And as I discussed earlier, there is a concept of tumor heterogeneity. So all the cells are not alike and all of them are not so responsive. The osimertinib unresponsive clones will emerge under the pressure of osimertinib therapy, and then they will start growing, and then they will not be responsive to osimertinib. So at that point of time, we have tried introducing chemotherapy for some time. And then once we've achieved a good response, we can put them back on EGFR TKI as a maintenance for, again, to give a chemotherapy break. So there is this concept of, and there are clinical trials also on this. There are phase 1, phase 2 trials where there is a cycling of therapies where we alternate or switch between the targeted therapy and chemotherapy. And it's not a standard practice, but we can use this strategy also, keeping tumor heterogeneity in mind, that whenever we're giving a targeted drug, the clone which is resistant to that drug starts emerging. So if you see, these are some of the real world evidence case reports on osimertinib and brain metastasis. This is a case of a 53-year-old patient who relapsed while being treated with chemotherapy for stage 3 lung cancer. Subsequent scans, they reveal pretracheal nodal hypermetabolism, and then there were multiple brain metastases on MRI while she was receiving chemotherapy. So osimertinib was started because she was found to be EGFR positive, EGFR L858R positive, and osimertinib was started at 80 milligrams daily. Patient complained of ataxia initially. Her ataxia worsened, and then gradually she was managed, and she was actually planned because of this worsening ataxia, probably worsening edema, since the largest metastasis was very close to the vermis, cerebellar vermis. So that's why she had to undergo a decompression, craniotomy, and excision of the tumor. But after that, she responded very well to osimertinib. And then gradually there was a decrease in the size, and there were complete resolution of symptoms once after a few weeks of, by the time she reached day 60, that is 2 months of therapy with osimertinib, most of the lesions have completely resolved. So this is another case report from real world evidence where there is complete remission of multiple brain metastasis in a patient with EGFR mutated non-small cell lung cancer who was treated with first-line osimertinib, again without radiotherapy. Again, here is a phase 2 study. It's like a case series where osimertinib demonstrated a high efficacy on brain metastasis, and all trial arms displayed a significant decrease in the number and diameter of the target lesions. So this is our initial patient who was started in, who was assessed in November 2021 and April 2022. By then, he had a complete response, and then now also he's doing quite well. So, Dr. Sindhura, do you think any other biomarkers are there which can predict the responsiveness to osimertinib apart from exon 19 deletion or L858R mutation? Do you think any biomarkers are there? Because we generally do NGS. So NGS gives us a lot of other mutations also, which may be present along with the EGFR alterations. So do you think any particular subset of patients or a mutation would, hint you that this patient may not be responding that well to osimertinib, or you may not be seeing those beautiful responses which you see with some patients?
So P53 co-mutation is one
Yes.
prognostic factor. So I had patient of who was started on Osimertinib.
Yeah.
So every time the scan shows a response in the existing disease, but some other disease comes back.
Yeah.
So that's how. So the patient had pleural effusion and pericardial effusion dominant disease. So consider continued Osimertinib and bevacizumab in such a patient. And these are the patients with 53 co-mutations who actually do very bad.
Yes, exactly. So P53 is one thing. If it's present concomitantly with any one of the other driver mutations, it portends a poor prognosis. And as P53 portends a poor prognosis in any cancer in general in oncology, so those cancers carry a very poor prognosis because they generally tend to have a very drug-resistant kind of a phenotype where they don't respond that easily. So if that's coexistent, then it is an indicator that this patient is probably not going to respond to anything. Even chemo may not work really well for such patients. So they generally do very poorly. So I had a patient who had leptomeningeal disease at baseline. She presented with a lot of headache. There were no brain parenchymal metastasis, but her CSF was positive. There was meningeal enhancement on MRI. So we did a CSF analysis in her and it was positive for malignant cells. She had a lung mass that was biopsied and she was EGFR exon 19 deletion positive. So we put her on Osimertinib and Osimertinib has responded. So patient has responded very well. And we also gave her triple intrathecal chemotherapy with hydrocortisone, cytarabine and methotrexate. And we were initially doing it twice weekly till the CSF cleared. And once the CSF cleared, we did it once a week for about 6 to 8 weeks. We have given once a week. And after that, she continues to take a TIT chemotherapy once in a month. And her first response assessment after 3 months of Osimertinib showed excellent response, near complete resolution of the lung lesion, the nodal burden, the skeletal burden, and meningeal enhancement also decreased, and CSF got cleared within the first 2 weeks itself. And her headache and symptoms of mainly headache and vomiting, they subsided. They significantly went down after being treated with Osimertinib. So we're continuing Osimertinib in her and with once a month triple intrathecal chemotherapy. So, key take-home points from today's discussion and food for thought are like radiotherapy for brain metastasis is probably not needed in all patients, especially if they are asymptomatic. We generally don't give if we are going for CNS penetrant EGFR TKIs like Osimertinib. Like our first patient had a complete resolution of brain metastasis just with Osimertinib. And there was almost complete resolution of the primary disease as well as nodes for this patient. And he tolerated Osimertinib very well and no adverse events were reported. And most of our patients tolerate it very well. We don't have to skip the doses or we didn't have to discontinue Osimertinib in any of the patients that I have treated so far. This patient remains progression-free even nearly 20 months after initiating Osimertinib. He's completely asymptomatic, fully active, and he's able to do all his regular physical activities and remain very physically active and leading a completely normal life. So these points we've already discussed that those patients who have an excellent response to Osimertinib, they're probably different definitely from those who don't have such a good response to Osimertinib. So with that, we'll end the panel discussion and we'll proceed for our next talk that is by Dr. Sindhura on selecting therapy for less common driver mutations in advanced lung cancer, MET, RET, ALK, ROS, and NTRK. Over to you, Dr. Sindhura.
I'll just share my screen. Just give me a second. So is my screen visible?
Yes, ma'am.
Yes, Sindhura, your screen is visible.
So fine. So I would be discussing about selection of therapy in the other mutations apart from EGFR. So as ALK is relatively more common, I would be discussing more detail about ALK and then move on to the other mutations. So ALK rearranged NSCLC is seen in close to 4% of NSCLC and predominantly female, younger age and adenocarcinoma, never smokers. So out of all the variants described, the most common rearrangement would be the EML4 ALK translocation, and this is supposed to be the most sensitive to all the ALK TKIs. So different variants influence the sensitivity and resistance pattern to TKIs. So ideally, it would be better to understand which are the fusion partners. So the most common one is highlighted in this. So we have different armamentarium of ALK TKIs. The first generation one being the crizotinib, second generation being the ceritinib, alectinib, and the brigatinib, and the third generation one, which is the lorlatinib. So it's also important to understand the toxicity profile of all the drugs to help us in the therapy selection. So crizotinib is associated more with the vision disorder, edema, ocular edema, and nausea and edema. Apart from that, lorlatinib is significantly associated with grade 3-4 hyperlipidemias and hypertriglyceridemia as well as hyperglycemia. And cognitive dysfunction is one important side effect which needs to be kept in mind. Coming to the other second generation TKIs, yes, they are associated with transaminitis and QTC prolongation. So the toxicity profile is hence important. So on comparison of the first generation TKI, that is crizotinib versus chemotherapy and ceritinib versus chemotherapy, it has shown that the progression-free survival is better with the ALK TKIs. So then came the next generation TKIs that we would next discuss is alectinib, that is the Alex trial, which is a phase 3 trial, which has compared alectinib versus crizotinib. So it has been shown that the overall response rate is better with that of with alectinib, and the median progression-free survival is 35 months with alectinib compared to crizotinib, which is 11 months, much higher compared to crizotinib. And in those with CNS metastasis, the progression-free survival with alectinib is around 28 months compared to 7 months with crizotinib. So alectinib had definitely resulted in a significantly better progression-free survival. However, the median overall survival is not yet reached. It has also given a significant OS benefit. The median overall survival in the crizotinib arm is around 57 months. And this is with respect to the CNS penetration. So alectinib is definitely more CNS penetrant TKI and has a higher efficacy in CNS metastasis with 12-month cumulative incidence rate much lesser in alectinib, that is 16% versus almost 60% in that of crizotinib. So alectinib is definitely a preferred TKI in ALK rearranged NSCLC compared to the crizotinib. Moving on to the other trial, that is ALTA-1, which has compared brigatinib versus crizotinib. It's again a phase 3 trial. So this also, in this trial also, it is shown that brigatinib is a better TKI than crizotinib in form of increased overall response rate, better intracranial efficacy, as well as a better progression-free survival. And the median overall survival is not reached in either of the arms. So the recent of the updates, that is the CROWN trial, which is the first line lorlatinib versus crizotinib in treatment-naive advanced ALK positive NSCLC. It's again a phase 3 trial. So lorlatinib has definitely got a better PFS, CNS efficacy, as well as better overall response rates and increased time to CNS progression. So the overall response rate with lorlatinib has been like 76% compared to 60% with crizotinib. And the median progression-free survival has not been reached in the lorlatinib arm compared to around 9 months in the crizotinib arm. So similarly, the CNS overall response rate is almost 3 times as that of crizotinib for lorlatinib. So if we see the efficacy of different ALK TKIs in the first line setting, we know that definitely alectinib, brigatinib, and lorlatinib are better drugs than crizotinib and ceritinib. So which one to choose all depends upon the toxicity profile. So considering and the presence of brain metastasis, the ideal preferred one would be alectinib or brigatinib over above lorlatinib, because if you see the median follow-up duration, it is much longer with alectinib. So the tolerability, the median follow-up duration and all, it's definitely longer with alectinib compared with lorlatinib in the CROWN trial. So I would prefer selecting alectinib as a preferable choice compared to lorlatinib and reserve lorlatinib for the second line therapy. And if a patient is not affordable to choose any of the second generation or third generation TKI, then I would either choose crizotinib or ceritinib. Personally, I would favor use of ceritinib because it has got a better intracranial efficacy compared to crizotinib as per cross-trial comparisons. So when choosing the ALK TKIs in subsequent lines, it's also important to understand the various resistance mechanism. So ALK mutations are the most common resistance mechanism. So it requires an NGS for the testing. So the most common mutation is a gatekeeper mutation of L1196M. The other ones are the solvent front mutation. The other signaling mechanisms like MET, phenotypic transformation to the small cell, and ALK amplification can also be there. So the mutation which arises depends upon the TKI used in the first line. For example, if a patient uses crizotinib in the first line, then it's non-G1202R mutation, which is more common. And if the patient uses second generation ALK TKI, then it is G1202R, which is most common. Why is this important? Because G1202R is actually sensitive only to lorlatinib, and rest of all the TKIs fail. So if a patient has been treated with crizotinib in the first line or ceritinib in the first line and has got this mutation on subsequent NGS, it is always better to choose lorlatinib because this is the only drug sensitive. So hence it is important to know the ALK mutation ideally, but still, yes, this is not routinely into our clinical practice. We just follow first line alectinib, then second line lorlatinib. If we choose a ceritinib or crizotinib on the first line, we generally go for alectinib or then lorlatinib. So this is a recent most ASCO guideline update. So let us see what they have said for the ALK rearrangement. So according to them, the preferred strong evidence is for alectinib, brigatinib, and as well as lorlatinib. So if alectinib or brigatinib or lorlatinib is not available, then they would choose ceritinib or crizotinib. If the patients had received prior crizotinib, yes, they have directly gone for either alectinib, brigatinib, ceritinib, or lorlatinib. But patients who received ceritinib can't be treated with crizotinib. Patients who received prior TKI with other ALK inhibitors, like the second alectinib or brigatinib, straight away it would be lorlatinib. There is only one mutation which is resistant to all TKIs but to crizotinib. That is, I think, L1196. So such things have to be dealt into detail if the patient is not responding as per our usual expectation. Moving on to the ROS1 rearranged NSCLC. So ROS1 is relatively rare, 1 to 2% of NSCLC. And yes, even though it is positive on IHC, it has to be confirmed by a FISH or an NGS. And the most common translocation is the CD74 ROS1. And again, adenocarcinoma, younger and never smokers are the most common. Unlike in ALK, since ROS1 is relatively uncommon, majority of the trials are either phase 1, phase 2 trials. So all crizotinib has been tested in various prospective and retrospective trials with around 50 to 100 patients. And the overall response rate has been consistent to be around 70% and with a PFS ranging from around 9 to 15 months. So crizotinib is a decent option. And coming to the ceritinib, it also had resulted in overall response rate of 60 to 65%. Yes, ceritinib is an option in those with those treated with crizotinib and as well as crizotinib naive. And the other ROS TKI relatively more selective for ROS. Of course, entrectinib is active against ROS, NTRK as well as ALK. So this data is a pooled efficacy and safety data from 3 early studies of ROS entrectinib. So this had both ROS as well as NTRK. These are ALKA trials, START-RK1 and START-RK2. So the overall response rate has been like close to 70% with a median PFS of 16 months and median OS has not been reached. And those with patients with CNS metastasis, the intracranial response rates have been close to 50% and the median overall survival of around 28 months. So entrectinib is again a good option in those with intracranial, brain metastasis with ROS1 positivity. Lorlatinib is again another choice, again preferred in a post-TKI setting. And it has resulted in an overall response rates of 60% in TKI naive setting and 35% in post-crizotinib. So as we know, the intracranial response rates are exceptionally good in patients treated with lorlatinib. And the median progression-free survival in naive setting is around 20 months versus 9 months with post-crizotinib. And the median overall survival has not been reached. So the phase 1-2 Trident trial has been reported only recently. So the overall response rate with repotrectinib has been like 80% in the TKI naive setting, and the median progression-free survival is quite encouraging, that is close to 36 months. So as per the cross-trial comparison, probably repotrectinib is going to come up in the treatment armamentarium. And similarly, as we saw with ALK, the resistance mutations are again the commonest resistance mechanism. So it's important to again identify the mutation and then choose our decisions. So as per the recent most guideline, crizotinib and entrectinib are the preferred options. And repotrectinib has so far not come into the thing. And if patient is post crizotinib, then lorlatinib is a preferred option. Moving on to the RET rearranged NSCLC, unlike the RET mutations we see in medullary thyroid carcinoma, it is the RET rearrangements that we see in lung cancer, and these are also seen in 1 to 2% of non-squamous NSCLC. And RET is carried by a higher incidence of brain metastasis. And we have two selective RET tyrosine kinase inhibitors, that is selpercatinib and pralsetinib. So the side effect profile with RET is more of hypertension, hemorrhage, hepatotoxicity, more of something like a VEGF. So we have two trials. So one is a phase 3 trial of selpercatinib versus chemotherapy plus minus pembrolizumab. So out of the two RET TKI, selpercatinib has been taken up for the phase 3 trial and have a longer follow-up compared to the pralsetinib. So the overall response rates have been like 84% compared to 65% in the chemotherapy plus minus pembrolizumab, and a median progression-free survival of close to 25 months. And selpercatinib has also been associated with very good intracranial response rates of close to 80% and good intracranial PFS as well. So yes, RET TKIs are also something very interesting. And as we discussed, Arrow trial, it has taken both patients in the treatment naive as well as treated setting, and it has also got a high response rate of close to 70%. However, the data is not so mature. So what does the guideline say about what drug to use? So selpercatinib, as it has a phase 3 trial, and a longer follow-up, definitely it has got a stronger evidence compared to pralsetinib. So it's the preferred drug. If patients has failed this, then it's the chemotherapy plus minus pembrolizumab, that is individual's choice. I think I would still follow only chemotherapy. Moving on to the MET NSCLC, I would not discuss detail because the following talk would be on MET. So it's the exon 14 skipping mutation, which is of importance to us. And it's important to look for MET especially in patients with sarcomatoid carcinoma. And it's basically seen more in older patients and more in smokers as well. So we have 3 different MET TKIs, that is crizotinib, capmatinib, and tepotinib. Crizotinib is a non-selective drug. Capmatinib and tepotinib are selective for the MET. So the MET specific side effects are edema and hypoalbuminemia, as we see in generally also. So crizotinib had shown a response rate of around 30%. And this is not a treatment naive patient. So basically patients have been treated with other lines of therapy as well. But I think MET skipping mutation is not as good as the other targetable mutations and other targeted therapy. So median progression-free survival is around 7 months. And in the Vision trial, the progression-free survival is around 8.5 months and overall survival of 17 months. And this again has taken patients with 0 to 2 prior lines of therapy. And capmatinib had also had a overall response rate of close to 68% in the treatment naive population and 40% in the pre-treated population, and a progression-free survival of around 12 months in the treatment naive. And long-term data is still awaited. So if a patient fails on this particular drug, I think one can choose chemotherapy with pembrolizumab, chemotherapy plus IO as an option. So what does the guideline say? It is again capmatinib, tepotinib as a choice, followed by second line treatment that includes a non-driver mutation. And the last section would be the NTRK rearranged NSCLC. We have 2 different NTRK inhibitors, larotrectinib and entrectinib. And the side effect profile of this particular drugs is neurotoxicity, weight gain, and bone marrow suppression. So NTRK receptors are involved in pain modulation, thermosensory regulation, and also in the body composition. Hence, these side effects are seen. And yes, the outcomes with larotrectinib has been quite encouraging, with a median progression-free survival of around 28 months and overall survival of 44 months, with really good intracranial response rates as well. So this is an integrated analysis, not just a single trial. And if we see the entrectinib as a similar, we have seen in the Ross rearranged NSCLC, we have a pooled data of the 3 trials, and the overall response rates of NTRK positive NSCLC is around 63% with a median progression-free survival of 28 months, and median overall survival is not yet reached. Again, this is a good cohort, and the TKIs are also like encouraging. So entrectinib or larotrectinib either can be our choice, and if one fails this particular therapy, and again it is standard treatment based on the non-driver mutation guideline. So with this, I would limit my discussion, and in case of any questions, I would be happy to take.
Thank you, Dr. Sindhura. That's a very exhaustive discussion presented in a very concise way. It's very difficult to cover so many mutations, but you've presented it in a very concise and a nice way. Thank you very much. We'll proceed with the next talk by Dr. Praveena on vision for MET exon 14 skipping mutation in NSCLC patients. Dr. Praveena is a medical oncologist from Visakhapatnam. Over to you, Dr. Praveena.
Yes, ma'am. First of all, I would like to thank Dr. Mounika ma'am, Kavina Creations and Mac for giving me this opportunity. I would share my slides now. Are my slides visible?
Yes, ma'am.
So, as ma'am said, today's my topic of discussion is on MET exon skipping mutations in NSCLC patients. So, as already discussed by previous speakers, this is the burden of lung cancer around the world and India. So we have so many molecular alterations in lung cancer now to target. Out of this, this MET exon skipping mutation is less common. It's seen in the 3 to 4% of patients. So for managing NSCLC patients, this molecular testing is of paramount importance in identifying these alterations. It is recommended according to guidelines for both adeno and squamous histologies, and as well as large cell and other histologies also. Almost all NSCLC subtypes, it is recommended, molecular testing is recommended now. So the gold standard for molecular testing is tissue biopsy. If tissue biopsy is not feasible due to various factors, then liquid biopsy is a suitable alternative. So there are different advantages and disadvantages of this tissue biopsy and liquid biopsy, which were detailedly discussed by my previous speaker. So this is the retrospective analysis which was published way before in 2019. In this study, they have analyzed patients with MET exon skipping mutations. So, and they came to a conclusion that MET inhibitors significantly improved overall survival compared to chemotherapy in patients with these exon 14 skipping mutations. So according to guidelines, both NCCN and ESMO guidelines, the preferred first-line therapy options for these patients are tepotinib and capmatinib. Crizotinib is a non-selective inhibitor. It can be tried if these drugs are not available or in certain circumstances. It can also be tried. So first of all, tepotinib, this was approved based on results from Vision study. It's a phase 2 study, phase 2 single-arm multi-center open label study. This is the first clinical trial of MET inhibitor to prospectively enroll patients based on liquid or tissue biopsy. It is the largest study of its kind, enrolled more than 300 patients with these mutations. And it included both treatment naive and previously treated patients, and also it has included patients having brain mets. Almost 18% of patients had brain mets. So it included mostly elderly patients because these MET mutations are most commonly seen in elderly patients with median age of greater than 70 years, and 30% of patients are Asian patients. This is the study design. As I said, it's a phase 2 study. At patients having advanced or metastatic cases having MET exon 14 skipping mutations were enrolled, and less than or equal to 2 lines of prior therapy are allowed. Cohort A was the primary analysis. Cohort C is the confirmatory analysis. The dose of tepotinib prescribed was 450 mg once daily, and around total 313 patients were enrolled. 164 patients were treatment naive. 149 patients were previously treated patients. Primary endpoint was overall response rate. Secondary endpoints were duration of response, PFS, OS, and safety analysis. We can see here the baseline characteristics. The median age was around 70 to 74 years in both groups. And around 30% of patients were Asians. And in treatment-naive patients, 17% were having brain mets at baseline, whereas in previously treated patients, 19.5% had brain mets at baseline. So patients were tested with both tissue and liquid. Out of these patients, 36% were positive on only liquid biopsy, whereas 42% were positive only on tissue biopsy, whereas 21% of patients were positive on both tissue biopsy and liquid biopsy. So coming to the efficacy results, in treatment-naive patients enrolled via tissue biopsy, the ORR, overall response rate was 58.6% with a median duration of response of 26.4. PFS was 15.9 and a OS of 29.7 months. It is very impressive in this group. In previously treated patients enrolled via tissue biopsy, ORR was 49.5% with a median OS of 20.4 months. And when coming to Asian patients, both in treatment naive and previously treated patient, it has shown very good results with a overall response rate of 64% versus 50%, with a median OS of 32.7% in first line patients and 23.7 months in second line patients, previously treated patients. So as I said, patients having brain mets also enrolled. Around 18% of patients had brain mets. It has shown very good intracranial disease control rate of 88.4% and with 66.7% of intracranial response. And intracranial median PFS was 20.9 months and the duration of response was not reached. And if you can see in this picture, MRI scan of one patient who is having 11.1 mm target lesion at baseline. It was completely resolved by week 36. So it has got very good intracranial penetration, very good intracranial response rates. So far, these two drugs, tepotinib and capmatinib, are the drugs recommended for these patients. Tepotinib was approved based on the results of Vision trial, whereas capmatinib was approved based on the results of Geometry trial. So brain penetration was higher with tepotinib compared to capmatinib. It is 25% with tepotinib, whereas 9% with capmatinib. And in the Vision study, as I said, it has got very good intracranial disease control rate of 86% with an intracranial response rate of 66%, whereas with the capmatinib in Geometry trial, intracranial response rate was 54%, which is also decent enough. Coming to dosing, dose of tepotinib recommended is 450 mg once daily, whereas for capmatinib it is 800 mg per day, 4 tablets per day. So, and the dose reduction schedule was simpler with tepotinib compared to capmatinib. When we compare the efficacy survival rates, the median PFS is around 15 to 16 months with tepotinib compared to 12.5 months with capmatinib in Geometry study. Of course, this is cross trial comparison. If you see the OS, it is around 29 to 32 months with tepotinib versus 25 months with capmatinib. It is slightly higher with tepotinib when compared with capmatinib. Of course, it is not a direct comparison. And also we see a matched adjusted indirect comparison between these two drugs. Median OS was 29.7 months with tepotinib in Vision study compared to 20.7 months with capmatinib. These indirect comparisons confirm the clinical benefit of tepotinib in comparison with capmatinib in these patients. This is the dosing schedule. As I said, the recommended dose of tepotinib is 450 mg per day, whereas capmatinib is 800 mg per day. It's a twice daily dosing. So if tepotinib is available as 225 mg tablets, it's 2 tablets per day is recommended, whereas capmatinib is available as 200 mg and 150 mg tablets. Patient has to take 4 tablets per day. When coming to dose reduction schedule is simpler with tepotinib. So the only one-step dose reduction, patient is not able to tolerate 250 mg 2 tablets per day. It has to be reduced to 225 mg 1 tablet per day. If patient is not able to tolerate even 225 mg OD, then it has to be permanently discontinued. Whereas for capmatinib, the recommended dose is 800 mg per day. That means 450 mg twice daily. Recommended first dose reduction is 300 mg twice daily. Second dose reduction is 200 mg twice daily. If patient is not able to tolerate even 200 mg twice daily, then it has to be permanently discontinued. So then coming to the safety profile, as already discussed by previous speakers, peripheral edema is the class effect of these MET inhibitors. This is the most common toxicity encountered, but the high-grade peripheral edema is lesser. Only 11% of patients in tepotinib study, vision study with tepotinib, only 11% of patients had high-grade peripheral edema. The toxicities commonly encountered were nausea, transaminitis, hypoalbuminemia, etc. Most of the toxicities are manageable. So then what is the main mechanism behind development of peripheral edema with this MET inhibitors? It is not clear, but it may involve inhibition of MET in vascular and lymphatic endothelial tissue, which may lead to capillary leakage. Then what are the preventive measures have to be taken while using these drugs? These are limb elevation. Second one is stockings, and third one is massage and diuretics and regular monitoring. In case of high-grade adverse events, we can do dose reductions or dose interruptions. Dose reduction does not significantly affect the efficacy of tepotinib as per the present literature. So as I have already discussed, this is the dose reduction schedule. If patient is not able to tolerate 450 mg OD, then it has to be reduced to 225 mg OD. And these simple conservative measures are effective in supporting these patients while on treatment. So then why should we prefer tepotinib in these MET exon 14 skipping mutations? Because it is, as already discussed, it has better brain penetration and has better intracranial response rates, and the PFS and OS are slightly better compared to capmatinib in cross trial comparisons. And it is the vision study is the largest study in these patients, and the first study to enroll patients with both tissue biopsy and liquid biopsy in both first line and second later lines of patients. And the dosing is also convenient. It's only once a day dosing, and the well tolerable drug, and only minor toxicities. Thank you.
Thank you, Dr. Praveena. That is yet another emerging area in molecular aspect of lung cancer, that is MET. So this lot of drugs are being approved, and this is another breakthrough. So with that, we end today's session. I thank all the speakers and panelists for actively participating in the scientific discussion and giving their valuable insights. It was very nice discussing the cases and personal experiences with you. I thank AstraZeneca for bringing us all together on this platform to share our experiences and exchange our views.